Welcome everyone to today's program. I'm Tamara Rosen, Assistant Editor with Becker's Hospital Review. The program will begin with a presentation and we will have a question and answer session at the end. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. The Senior Vice President, Lee Hedman, manages surgical direction, service delivery, and implementation projects. Leveraging her deep healthcare and consulting experience, Lee orchestrates teams of physicians and nurses as they identify opportunities for service improvement and implement best practice standards that help hospitals sustain the long-term competitive edge. Lee also leads the Anesthesia Revenue Cycle Consulting Division, where she has successfully worked with practices to improve revenue cycle processes and improve financial performance. Lee has authored articles about anesthesia best practices, and she served on the ASA's Conference Advisory Board. Yvette Stanley is a project manager for surgical directions with over 19 years of experience providing financial analysis, human resource management, project management, and strategic planning within the healthcare industry. She also leads the Anesthesia Revenue Cycle Assessments team for large acquisitions in the anesthesia market. Her management expertise covers a range of complex business activities with specialties in anesthesia, hospitalist, pain management, and pulmonologist fields. Previously, Yvette was the operations director of a large billing and anesthesia company, where she was responsible for planning, directing, and coordinating the operations of the billing and management division. She's a member of the Society of Human Resource Management, Medical Group Management Association, and the Georgia Anesthesia Administrators Association. It is now my pleasure to turn the floor over to Lee to begin today's presentation.
Good afternoon. Thank you for having us, and thank you on behalf of Surgical Directions. We hope in the next 45 minutes to an hour that we can really share a lot of our experiences with you. We know one of the key topics right now as we travel across the country as consultants is the growing need for anesthesia leadership. And that means a lot of collaboration in the OR, which is where we spend most of our time when we're at hospitals. Next slide, please. Just to give you some background on Surgical Directions, we specialize in healthcare consulting, and we're comprised of professionals with deep experience in specific areas of focus. We work side by side with our clients to get absolute impact and sustainable performance. One of our unique models is our peer-to-peer model, which is a little bit different for consulting, where we match physician to physician. Typically, we have anesthesiologists on the road with us because a lot of the work we do really impacts what happens with the anesthesiology practice. We also have executive nurse consultants that work directly with the managers and directors of the OR. And then from the executive level, we meet with the C-suite to let them know what's going on in their OR, try to educate them if in different circumstances where that is necessary. And also we have business analysts, which really look in depth of what's going on in anyone's OR. So the combination of the knowledge, experience, and all of the processes that we've put in place has really been able to give us consistent identity and implementation of improvements, and over the long-term operational, financial, and really good objectives for our clients. We do follow our clients for years to come, and most of the processes stay in place. At times they ask us to come back and kind of do a little redo and get everybody back up to speed because the process works and starts to move forward. Most of our focus, too, really ensures that we look at the efficiency of the OR, which, of course, in this day and age looks at the cost-effective part of it as well, so that we have financial results that are positive. One of the things we pride ourselves in is really challenging the status quo, because we've really looked at that peer-to-peer model to make it lasting change, but part of that is really doing a change transformation within the OR. So if we have a nurse working with the nurses and physicians working with physicians, you're really going to get more of a buy-in so that you can continue to move the project forward and really change the way the OR is functioning. Next slide, please. So Surgical Directions has about 500 plus companies that we've worked with, different hospitals that we've worked with. As you can see from the wide variety here, we've been all the way in Alaska. We've done NYU Langone Medical Center, which is a large academic center. We've worked in community hospitals and all different practices across the country. I think the best thing that we bring to the table is our peer-to-peer model, and the thing that we really get together is to really put everybody on the train when we get there, and we tell them it's, leaving the depot and we'd like them to come along. A lot of people have trouble with change, but part of what we do is collaborate through the OR, and part of that is with leaders such as the anesthesiologist. Next slide, please. The first thing we do when we get a call to come to a hospital is really make everybody understand why we're focusing on perioperative services. A lot of people, including people at the hospital, don't realize that perioperative services really is the key to the hospital's success because it drives about 68% of the revenue. In today's world, in the healthcare world, obviously, value equals outcome, but that's divided by the cost. So we really have to look at the efficiency of the OR, what the staff is doing, what the supplies and costs to that are, and bring that all together. And part of the reason that the OR is so important is it's not only the day of surgery, but it's the days prior to surgery, all the testing, the lab tests, the x-rays, the different appointments that the patient has to have, and then obviously the follow-up afterwards. And that could include things like physical therapy, additional radiology testing and things like that. So it's the whole process. So it just isn't a couple of hours the day of surgery. Next slide, please. So successful health systems really turn to anesthesiologists. The health systems today are really under pressure to improve perioperative clinical outcomes, improve their financial performance, and obviously as we all move to value-based care delivery system. So the anesthesiologist can help lead that way in transforming perioperative services by stepping up and being the medical director, which we'll talk a lot about really running and cheerleading the pre-admission testing area, working on first case, on-time starts, and turnover time with the nurses and everybody else that is trying to get through the day within the OR walls, and also to be the board runner, really be up looking at the cases to look and see what can be moved, what's the best for the patient, and what's the best for the day of service. Next slide, please. Part of what Surgical Directions really focuses on, too, is the collaborative governance. So it really starts by eliminating the silos. A typical OR has always been broken down by the surgeons do what they want. Anesthesia is really constant in the OR, but they're, taking care of the patient and really being within their own clinical area. And then we have senior leadership that most times doesn't even visit the OR, but again, it drives 68% of the hospital's revenue. And then we have the OR nursing leadership, which the OR nurses, if you know about across the country right now, nurses that have been OR directors can really go anywhere in the country because there's so many openings for good, experienced clinical directors. And one of the reasons behind that is because they've really worked up from the ranks as staff nurses. And once they get through the management level, they're really working at a very high level with multi-million-dollar budgets and really working on a day-to-day basis to make sure the OR runs smoothly. So part of bringing together a collaborative governance is to bring all of those constituents together around the table a couple of times a month to really put an agenda together of things that need to be done within the OR to make sustainable change. And we usually have that chaired by two co-medical directors. One is a surgeon who really leads the meetings, and the other one is an anesthesiologist, which is really the medical director or the day doctor in the OR that really works in collaboration with nursing to make the day go smoothly. Part of senior leadership, the reason that they usually get involved in the OR is when a surgeon or a patient's family isn't happy, and then they go to the senior leadership for rectification on it. But if you really work this through the collaborative governance and have everybody working together, there should be no reason for anybody to run down to the C-suite. This is a different committee because it is actually appointed by the CEO of the hospital. So it's an operations committee, not a medical staff committee. And the difference is really having all those constituents working together. Next slide, please. One of the topics we wanted to touch on today is to really look and find a gem within your anesthesia providers. A lot of hospitals that we go to, you know, it's always the chief of anesthesiology, and that's not always the right person to be on the day-to-day operations because he or she has a lot of other responsibilities. Next slide, please. So we look for an anesthesiologist that has leadership skills, and our characteristics of effective anesthesia leadership are a couple of key things. First of all, they need to be clinically respected. They need to have good clinical outcomes and put the patient first. We also have to have collaborative approach, and that means on the day-to-day activities to really work, like I said, with nursing and with everybody else that brings things to the OR, the sterile processing department, materials management, the techs, and everybody else, so that there's a smooth day and there's a just culture within the OR. We also have to have a leader that is trusted by the surgeons, nurses, and administration. Somebody that people look to when they have some issues or look to for suggestions on how to do things differently or how to do things better. They have a voice within the OR. And then the last thing, of course, is decision making. We have to have somebody that's in a leadership role that can make managerial decisive decisions. So when something is going on in the OR, you have to really think quick and make the right decision for not only a patient, but for the entire OR to make it a safe and efficient day. And also somebody that is results oriented. So processes that we put in place today, we keep tweaking them until they get to be absolutely hardwired. And then we constantly go back and look and see if we can do anything better. If there are any issues that go on within the OR, it's very important for the anesthesia leader as well as the nursing director to get together and really look at what caused the problem and really do a deep root analysis to find out what really happened and what we can do to prevent it in the future, not to just let it go. Next slide, please. So part of our suggestion is to really find that medical director of the OR and appoint the medical director to work with nursing leadership and hospital administration. So this person really gets interviewed. It's just like getting a whole nother job, but really gets interviewed by surgeons, nurses, administration, and then everybody comes together and decides who would be the best fit. And usually we have that person really be the medical director for at least 2 years so that whatever is put into place, they can really work on making it sustainable. They also chair the SSEC along with their surgeon partner and really help to put those agendas together, whatever is going on in the OR, and have open discussion and actually have voting rights and really make decisions. And then also, as we talked before, is to really work with the nursing director. It's so important to bond with the nursing director and to really work with he or she on a day-to-day basis because it's an overwhelming amount of responsibility. But if you work together, things really do go smoother. So the medical director that has a lot of strengths would have the strong clinical skills, obviously strong leadership skills that we spoke of, have a collaborative approach to problem solving, work by gathering consensus, not by dictating policy. Really ask people's opinion, really listen to the other nurses, the techs, and everybody else that's within the OR, and then make decisions. Sometimes those are hard decisions, but nevertheless, They have to be made, and you have to be the leader to stand up and do that. And we really feel that because an anesthesiologist is in the OR on a daily basis, not just 2 days a week, that they're really more apt to be in tune with what's going on a day-to-day basis. So it's not just a snap decision for something that happened today, but really to think long-term as to what's going to be best for your OR. And obviously to maintain a clinical practice. Even our physicians that work with us as consultants are clinically active. We feel this is very important because that way you know what really goes on day to day and from month to month and year to year. Next slide, please. So the medical director of the OR, like I said, will be responsible for setting the SSCC agenda with the surgeon medical director and really looking at what the priorities are and delegating tasks and monitoring the progress. They're responsible for addressing physician-related issues. If there are physicians acting out or physicians that need additional block time or they're not using their time effectively, they really need to be able to stand with those physicians and really discuss things in order to rectify what's going on. And working with the RN director, the nurse director, who has operational authority for all of the different pre, intra, and post-op policies. So if any of the policies need to be revised, you need to do that in collaboration. The anesthesia deployment is very important. How many rooms are we running? When do we do our drawdown in the afternoon? How many rooms do we run overnight? What do we do on the weekends? And also really focus on the NORA sites, the non-anesthesia sites, so that we make sure that we have adequate coverage. We don't want physicians or surgeons coming in and having to wait because we don't have anesthesia coverage. The scheduling, obviously, for daily and long-term needs to be in conjunction with the nursing director as well, so that he or she can also look at their staffing. I know as we go around the country, especially in the last year, there's a lot of days where there aren't enough cases and the nurses get sent home. And in order to be able to monitor that, we need to know what our daily schedule is ahead of time. And Yvette will talk more about the daily huddle. We also monitor the scheduling in conjunction with the Director of Surgical Services, the nursing director, to really look at what's going on with the block scheduling, bring that back to the SSCC, look at the overall utilization of each surgeon or each service's utilization of their block, and also look at the room utilization. Next slide, please. So we're looking to drive the performance in the OR by putting these measures into place. Next slide, please. So just to recap, anesthesia's role is to drive perioperative performance, and part of that is participation in a daily huddle, which we'll talk more about, to be an effective medical director, to make sure that your incentives and your group's incentives are aligned with the hospital, to be a strong leader, to really look at the surgical home and bundled payments that, to bring your group up to the standards of the ASA at this point, and to well position your group for the future. Look at possibly having available regional blocks. If that is something your group does, that's great, and if not, that is a great service. Look at pre-admission testing, and Yvette will talk more about that, how important it is for anesthesiologists to really be responsible for that. Look at first case on-time starts. If the day starts on time in all of the rooms, you're all going to have a better day. And if it starts late, if a couple of rooms start late, then the whole day everybody is going to be off on that work-life balance. The patients are not going to be happy and the surgeons are not going to be happy. And then to make sure for PAT that your protocols are evidence-based and everybody is able to agree on them, which will ultimately help grow the case volume and improve the bottom line. Next slide, please. So how do we drive perioperative performance? Just as I've just mentioned, effective medical director. We can't emphasize too much how important that is. There are places that we've been, obviously, that don't have a medical director in place, or would have the typical, we have a medical director, it's the chief of anesthesia. And most times we find that that's not usually the best person to be in that role because he or she has other additional responsibilities. And just by talking to the different anesthesia providers, you can really find a couple of people that are just eager to be leaders but have never been asked to come forward. Some of our best medical directors over the last 10 years that we've chosen and mentored are people that would never have thought of stepping up to the plate to be a medical director. Make sure that the incentives are aligned. Make sure that the missions are aligned with the hospital and the anesthesia group in the OR. If you're not all moving towards the same goal, then you're just bumping heads, and that makes for a lot of frustration. If you haven't started regional blocks at your hospital, we find that that's very important. It's a service to not only the patients but to the surgeons. And pre-admission testing obviously should be protocol driven. You should look at all the comorbidities, really look at how you can service the patient best, how you can work with the patient's primary care provider, as well as maybe their cardiologist, to make sure that they're going to have a good outcome. And obviously, as anesthesia providers and as medical director of an OR, you should always have the ability to accommodate add-ons. And that has to do a lot with staffing and also a lot with monitoring the block schedule and going peer-to-peer and talking to the surgeons that are not maximizing their block. Next slide, please. The participation in the daily huddle, Yvette will go into detail on that, but we find that to be very important because that's a daily get-together, a daily collaboration of everybody working for a smooth day in the days to come. Like I said, on-time starts. A surgeon is only going to be on time if he or she knows that the patient is going to be ready. So if there are bad habits where, you don't get around to getting into pre-op holding and taking care of the patient and going over the anesthesia consent, going over all the different things for the procedure with the patient, then the surgeon is going to be late, and that's going to set everybody's day back. Obviously, if you can participate in the turnover time, it's always best. That's not my job. It's really about the collaboration and working together. And having a just culture. The days of yelling or throwing instruments or not being kind to each other is really a thing of the past. And part of that is really the 10 points to safer surgery. Next slide, please. Yvette, you want to take it from here, please?
Sure. So let's talk a little bit about collaboration and how essential it is for the culture to change in the OR. We strive and teach and mentor when we're speaking with our clients that that's a very important element. Next slide, please. So teamwork. We ask that when we go into the institutions that people think really hard about what makes the team function and how can we work together. It's a group effort, and through collaboration, we can create some cohesiveness to really move things forward. Oftentimes, people are operating in silos and can't seem to move things because they're not understanding how one thing is impacting another because they're not talking to each other. So surgical directions with the peer-to-peer model and the collaboration, we create that teamwork, a partnership so that we can work in a group manner. Next slide. So developing a collaborative approach, what does that mean? For us, it means what we call designing a performance improvement team. We call them PITs. But those performance improvement teams are very important. We like to engage the staff so that they can be involved in making decisions and making changes. For example, when we talk about the process optimization, that's a performance improvement team. We look at first case on-time starts, turnover times, parallel processing, so that the staff can make decisions on how they see things can function in a better, more efficient way. Oftentimes, the staff don't feel empowered to speak up. So when we form these focus groups, these performance improvement teams, we interview people just like we do with the medical directors and the committees, and we talk to them and say, well, give us your ideas. We want them to come with solutions. Oftentimes they may have a lot of things they want to just get off their chest, but ultimately it's not a session to gripe. It's a session to excel and make suggestions on how we can improve and make things better. So the staff is involved in that, optimizing the process flow. We're looking at ways to improve and how we can cut out waste. And we do that oftentimes with lean mapping. We have process maps that we have the staff involved in. What is the current state? We try not to focus on that because we know that it's a broken process, but we also try to say, okay, how do we want it to look at the new improved state? How can we do best practice in our facilities? So along with that, scheduling and pre-admission testing is the same format, but these are just some examples of how we institute the staff to be able to empower them to participate in the transformation. So when we form these PIT teams, we round table and we establish first off the measurable goals, and we use the SMART methodology: specific, measurable, attainable, relevant, and timely. With those, with that acronym, we go about trying to establish what are we going to get out of this round table. We meet in sessions twice a month, sometimes more. We have breakout sessions just so that we can solve problems, but it's very organized and collaborative. Next slide, please. So through collaboration, through teamwork, Tuckman's stages of team building, we use the Tuckman's technology: forming, storming, norming, and performing. As I described to you before, the various performance improvement teams and some of the focus groups, we recognize that the team members are really important. So we need to have people that are going to be available to actually sit in on the sessions and then be able to come up with those solutions, the problems, and prioritize how are we going to resolve these issues. How do we break down the barriers? How do we remove silos? By doing this, say for example, you may have a performance improvement team for first case on time starts. That's not just the nurse in the OR. That's scheduling, that's PAT, that's screening. That's everything that leads up to the point of getting that case started on time. So the collaboration is in various specialties. It's not just one silo. So that's how we form those teams and put people together. We also want to identify in the performing process how we can negotiate and agree. So we actually vote, and make recommendations, and we send those up to administration for approval. But we look for people that are going to become champions of the process. They know it, but maybe they just haven't been empowered to demonstrate it or voice how they feel the right way should be. Next slide, please. The daily huddle. This is one of surgical directions. We really strive with the daily huddle. And the purpose of this is to reduce inefficiencies of real-time decision-making opportunities. We bring multiple departments together to work as a team, and it's once daily. So let me just explain to you how this works. What's really important is to have a scheduler, someone from anesthesia who can make decisions real-time about can this patient be the first case of the day or not. If it's a person coming from a nursing home, would that be the right person to be the first case of the day? Maybe not. Maybe we need to call Dr. Smith's office and say, hey, we need to massage this schedule a little bit. Maybe they can go later in the day. But if you can coordinate the resources, even instruments, to say, well, we don't have, this rep isn't coming until 10 o'clock. Well, that's not a good first case of the day. If this is a teaching moment, maybe that's not a first case of the day. But to reduce the hands-off mentality, that is not my responsibility. People are collaborating together. They're looking at the schedule. They're looking at comorbidities. They're defining, do we have instruments? Are we going to be ready? That way we're able to decide together as a team, not the morning of, in the morning, but 2 days out, 3 days out. When we first start this process, it usually takes about 45 minutes to an hour. But we've been in institutions where the ORs, it may be 25 to 30 ORs, and you can get through it fairly quickly in about 20 minutes. It's just a matter of prioritizing. But it's all about bringing together your multiple departments so they can work together as a team, understanding that they need to coordinate the resources. It makes for a more predictable day, for adequate staff for both nursing and anesthesia. It gives anesthesia the opportunity to take the lead in a lot of things that they are aware of that the surgeon's office or the scheduler may not even be aware of. It reduces the hands-off. Next slide, please. So who should attend? The medical director, someone from anesthesiology, a scheduling coordinator, your service line coordinators, posting office, and then you go through your perioperative planning, AM admit, central supply, and your perioperative nursing director and or manager, just depending on the size of your institution. This is just an example. Sometimes there are more individuals involved, depending, or less. Next slide. Pre-anesthesia testing. So what we like to do is create a single pathway to scheduling. That's what it's all about. All of these components, the medical director, a simplistic, standardized telephone questionnaire, the single pathway to scheduling, risk management strategies, and testing protocols, along with your comorbidities in a standardized, fast, effective PAT. We're all striving in the anesthesia world. How can we get that patient boarded and cleared for surgery in an effective way? Next slide. So, pre-anesthesia testing improves clinical outcomes. And the way we improve the clinical outcomes is through managing patients' comorbidities proactively, and we decrease in readmission rates and post-surgical complications. Also improving the OR efficiency, the first case on-time start that we talked about. We want to decrease the case delays and cancellations. As you know, the last thing you want is for your patient satisfaction scores to decrease because the patient's been called in and they've been on NPO since midnight and their case doesn't go until 3 o'clock in the afternoon. Huge dissatisfier, having to sit and wait, and a lot of anxiousness, and families aren't happy, and the surgeons aren't happy. So pre-anesthesia testing can alleviate a lot of that, decrease the same-day cancellation rate. At surgical directions, we do a lot of analytics so that we're tracking those actual delays so we can identify where are the hiccups, the choke points, so that we can alleviate those problems and collaboratively solve them with the office, not just the office, but your staff, the surgeons, the peer-to-peer relationship that we talked about earlier. It's instrumental in breaking down some of those barriers because we can have peer-to-peer conversations about being late. It doesn't fall just on the nurses. It's not something that is in a vacuum. It's in a collaboration peer-to-peer. So what does that do for pre-anesthesia testing? Well, it improves surgeon, staff, anesthesia, and patient satisfaction. In addition, we want to improve the financial performance of the hospital. Oftentimes when we're called in, there's some financial constraints going on at the hospital, and we want to be able to improve the satisfaction scores, decrease in readmission rates, and decrease in SSI and post-surgical complications. Next slide. So the goal is standardization. We can get everyone aligned through administration, anesthesiologists, your primary care and hospitalists, and some of the surgeons and staff. Then we can kind of go in that ring, that standardized fashion where people can say, okay, this is what I can expect, and we're not ordering EKGs when we don't need to. We're not sending people back because, oh, we need a pregnancy test. And so we use a lot of Cleveland Clinic examples, models, tools in order to assure that our client has a standard way, a pathway to get the patient cleared. But our anesthesiologists are at the forefront. They are working alongside of the group, the PAT, the performance improvement teams, in order to assure that everyone is satisfied with the method in which they are planning to get the patient cleared. Next slide. Tips for a timely daily schedule. So as you know, if you start the day late, you're going to end the day late. And it's going to create a big staff, big satisfier. We want to make sure that we can control our controllables. Some things we can't control, but there are predictable scheduling models that we can tap into and create a pathway that we have some room. We call it wiggle room, so that if you've got some open rooms, that you can use those accordingly. Next slide. So some of our key elements that we like to use and we found to be successful are, of course, the daily huddle. We look at case time. I talked about the data and how we like to compare what your current state as to what you should be in best practice, and we measure case times. We like to look at pre-admission clearance and assure that that is optimal. Block utilization is another big predictability factor when you're looking at the overall flow of the operating rooms. Sometimes the block schedules are not aligned. We want to look at the utilization, and we forecast to really look at, okay, how has this physician functioned in the past 6 months? What has been his case volume? How many times has he been late? How many times has he been over in his actual scheduled surgical time? Is he going by the scheduler's office and saying, I only need 45 minutes for this case when he knows he needs 3 hours? First case on time starts. Another thing is, getting cases started on time. We want the staff to be able to have some predictability and work-life balance, that they know, okay, if their shift is 12 hours, it's 12 hours, but if it's 10 hours, let it be 10 hours. Not running out in the hall at 3 o'clock or what we call the witching hour and saying, oh, I need you to stay for 2 more hours, and that's never happy staff. Turnover time, we like to improve the turnover time, and that's one of the hardest things to do, is to improve turnover time. But if you can get collaboration through your staff and the various methods that we spoke about, turnover time will decrease. And then, of course, staffing. Not only do you want to make sure that you can recruit good staff, but that you can keep what you have, and that's through predictability. Oftentimes, people leave because there's no predictability in scheduling. So that's a huge satisfier if we can get the staffing right. We have a lot of tools in surgical directions that we use to help define what your staffing model should look like, the number of nursing staff, anesthesia. Sometimes people struggle a lot with, well, what should my rooms running look like? What does my drawdown look like? Is it aligned with my contract, or is it aligned with the hospital and what they really want? And then, of course, equipment and supplies, assuring that central sterile process is involved and that materials have a hand as well and a seat at the table. Next slide. So we want to make a positive impact by patient satisfaction, surgeon satisfaction, and quality outcomes. All of these things make for a better OR and more productive and profitable OR. As we talked about in the first slide that we reviewed, 68% of the income for hospitals comes from the operating room, and we want to make sure that patients have been successfully optimized for surgery, but we also want to make sure that nurses and staff feel that they are in a just culture and that we have those good outcomes. Next slide. So anesthesia is the key to success of the OR. We want to develop a code of conduct for your department. We have many models that we work to tailor and customize toward you so that your department can feel like they can feel in a just culture manner to treat every coworker with respect, to being on time in the morning. These are just some examples of things that we would include in the code of conduct, and agree on an anesthesia protocol. Anesthesia is involved in making those decisions. We want them to be able to agree as a team so that even if you have one group, everyone's going by the same set of protocols, whereas sometimes we go places and there's 6 different standards or protocols, and, oh, no, I ordered this. No, we don't need that. So just to get everyone talking about it and on the same page makes things a lot more efficient. And then assist coworkers with first case on-time starts and turnover times. Can't stress enough how important it is, the value of improving satisfaction for everyone within the OR and along with your patients and surgeons to create that life-work balance for all and to be service-oriented at all times. Next slide. So how do you achieve work-life balance? I know that probably everyone on this call wants to know the answer to that, and we don't say we have a magic wand that we can wave and make it all better, but we strive to work together with your groups and with the hospitals and surgeons to create that collaboration so we can help to orchestrate the first case on time start, to start your day out right so that we can at least be going in the right direction, and to work with surgeons to fully utilize their block time so that they're not saying, well, I've been here for 30 years and why can't I still have 2 rooms blocked 4 days a week even though I'm only using 1. And then to assist with turnover time, streamlining that process, and review the schedule 3 to 5 days out through the daily huddle, and then agree on a just culture. We feel that these elements help to achieve your work-life balance. Next slide. Now we can open up for questions.
Great. Thank you, Lee and Yvette, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A. So we have a couple of questions to start off. The first one is, should the medical director always be the chief of anesthesia?
I can answer that one. This is Lee. We don't advocate necessarily that it's the chief of anesthesia, and one of the points I brought up earlier in the discussion is he or she has a lot of other responsibilities as the chief. We tried to look at somebody within the group that hasn't had the opportunity or is just starting their career as a leader, because we feel that you can really foster that relationship with the chief of anesthesia, with the director of nursing, and really bring that all together by training somebody that his or her daily objective is not only to take great care of the patient, but also to be the eyes and ears of the OR and really work at that board, looking at the cases, like Yvette said, how can we move the cases around so that, you know, everybody is taken care of, but in a sensible and timely fashion. So we would advocate, most times it would not be the chief of anesthesia, it would be somebody else from within the group.
Wonderful, thank you. Here's another question from the audience. What is the major uphill battle when trying to put together a well-functioning pre-admission testing department?
Yvette, do you want to take that?
So a lot of times when you're putting together a well-functioning pre-admission testing department, you want to make sure that, again, standardization is the key. We want to have, and surgical directions has a lot of tools that we can provide. There are a brief questionnaire so that the patient isn't answering 100 questions at one time. It's kind of like a tree, so a decision tree. There's 6 or 7 questions. If you answer one way, you go in one direction. If not, you go in another. It may lead you down the path of, oh, that person needs to come in. Oh, no, they don't need to come in. So it's a matter of standardizing that process. That's the biggest thing. And sharing it with your community so that your surgeon's offices are aware of what those protocols are.
Great, thank you so much, Yvette. Here's the next question from the audience. Does the discussion of just culture include all team members speaking up on behalf of the patient without fear of alienating those above them in the OR hierarchy?
I can speak to that one.
Okay, we can both speak to that one because we really believe in a just culture. I'll take a few seconds, Yvette, and then you can finish up. We do believe that everybody that is within that OR taking care of that patient has the right to speak up. You know, wrong site surgeries, you know, physician behavior, all the different things. We advocate, obviously, the timeout procedure. We like to see it posted. We like everybody to step back away from the table and stop, take a breath, and really go through that process. It's so important. Yvette, you want to take the behavioral part of it?
So oftentimes we get this question, and it's really simple. It's feeling that you're supported and that you have the ability to not have, that you're not going to have retaliation. So collaboration, again, is the key. Having everyone at the table so that the physicians can hear the staff, the administration can hear, and a lot of times we like to include quality at the table so that they can support. And once it's all in a collaborative fashion, then people can feel empowered to say, you know, it's okay to speak up and to talk about the issues that are at hand. Very important.
Thank you both. There's another similar question about just cultures here from the audience. So how exactly do you implement one?
I'll take it, Lee.
Okay.
So when you remember probably us talking about the performance improvement teams. So again, we form that group. And when you're forming that group, you've got to have administration at the table. You need to have nursing leadership at the table, a surgeon at the table, people that are working within the OR. You bring everyone into that room. The first discussion point is to really talk about what does just culture look like and how can we agree on what it should be demonstrated as within our institution. And that starts the conversation. We also say this is a safe place. You can speak up and talk about it. So that's the first steps in starting out a just culture environment.
Thanks for that. The next question from the audience is, when the OR has a poor performance on turnover time, what expectation of improvement can be expected?
I'll take that one. This is Lee. What we typically do is really look at the overall turnover time, and then we go and we look at case by case, and we do mapping on that, process lean mapping, to see how many people are in and out trying to turn over that room. And then we time the whole thing from start to finish, from the time the patient leaves the room to the time the next patient comes in. And by doing that and breaking it down, you can really look at what some of the problems are. A lot of times you'll find that it's just not, environmental service doesn't get up there in time, or they're not being utilized anymore. You can find that they're not working in a collaborative effort. You know, if a nurse can be standing around versus helping an anesthesiologist or a CRNA, if they just helped for 1 minute, it would make all the difference in the world. But to start out the process, we typically look at maybe one OR and make sure that we spend the day with that OR on every one of the turnovers to really find out and break it down to see what the issues are, what we can do to change it, and then take it to another OR and really maximize the efficiency by looking at what specific problems are related to the OR for turnover time. What can we do to change it through our process improvement team? And if we need administrative support, then we go to our governance council and say, for instance, we really need environmental services to do a total cleaning of this room at such and such a point. So really work to find out what the issues are, really work to motivate people, do a lot of parallel processing. It all doesn't have to be sequential. It can be parallel processing where one person is grabbing the garbage, another person is mopping the floor, and those type of things to really get people to work collaboratively as a group. It can make all the difference in the world.
Let me add to that. I think they were asking too, what improvement could we typically see. Best practices for a turnover, and depending on the specialty, sometimes it can be shorter, but we say around 28 to 30 minutes for best practice. But we typically see like 60 minutes when we were starting out, 60 minutes or greater, depending on the situation. We can usually get very, very close to best practice, if not better.
Thank you both. Another audience member asked, so the medical director should be from anesthesia. How do you navigate if other physicians are opposed?
I can start that out. Go ahead, Yvette.
Yeah, these are really good questions. We get excited about them. Yeah, so we typically put together the medical directors, and a lot of times the institution doesn't want to make a decision about who should be the medical director. They want a third party to come in and talk and speak to and interview and vet out those candidates. So we've been very successful at being influential on who the right fit is for that job. And we have job descriptions for that we like to share, not only with the administration or the decision makers, but also with the candidates so they know what the expectations are.
Right, because obviously the medical director that is chosen needs to spend, X amount of hours. When you first start doing that, it can tack up some significant time until you get the OR running as well as it can be. So there is a lot of, you got to step up and really be willing to take on more responsibility. If people are opposed to that, then we would ask, what do you think the better fit is and why? Let's figure this out. But day by day, dollar for dollar, we believe that the best fit is an anesthesiologist because they're in the OR on a daily basis. They're not coming and going.
Great. Thanks so much, both of you. It looks like we have one more question here from the audience before we wrap up today. So the last question is, as a point of clarity, is the daily huddle a review of only one surgical day? And if a huddle is occurring daily, how are you able to get staff out daily without interrupting the workflow in the OR?
The daily huddle, we start out looking at the next day, but once it gets running smoothly, we like to look 3 to 5 days out. So how it works is we usually try to do it between 1 and 2 in the afternoon. I think, as Yvette probably touched on earlier, that the first time it might take 45 minutes, But once you get it down, you're only looking at the exceptions. So everybody comes, usually just really stands at the front board or stands around a conference room table, and the scheduler goes through, this is what we have, these are the things that are missing, this is what we need to work on. So then you're only looking at the exceptions, and that's how we're able to do it in 10 to 15 minutes and keep it rolling and really look 3 to 5 days out. So by the time that 5th day gets to be the 2nd day, hopefully you've resolved 90 to 100% of those problems so that you have a smooth day the next day. It's a work in process.
Wonderful. Well, that's all we have today for the Q&A. I want to again thank our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.